It is 10 o'clock and we are ready for our weekly coronavirus virtual information session. I want to welcome all of you on behalf of the Traeger Institute. My name is Anna Fall, the Executive Director, and we are really looking forward to today's discussion about a status update on COVID-19 pharmaceutical interventions. So I am going to first, I'm going to first start before we introduce Dr. Kenny. If Dr. Furman can just give us an update, but before that, I need to talk about the best practices. I'm sorry, I'm populated this. So please keep your mics off. And then if you want to ask a question, you can type it in the chat. If you are concerned about your health, please call us at 588-4340 or call the Kentucky COVID hotline at 1-800-722-5725. And then if you have any difficulty with your sound, you can just look at that little arrow there and see if you can get it fixed that way. And then the next slide is, I believe, is going to ask you to type in the county that you represent in the chat. So I guess that is it for today. So I'm going to ask Dr. Furman to give us an update.
Hi, everybody. This is Dr. Christian Furman. I'm the medical director here at the Traeger Institute, and just want to give you a few things. The big update is the governor on Friday, Thursday he announced it, and Friday it took effect, Friday at 5 p.m. that now there's universal masking. So in public spaces and outside, and everybody's supposed to be wearing a mask. And it's so crazy looking back to, I did an interview on NPR and I said, oh no, you don't have to wear a mask. And this was like, before. So I think the problem is people getting mixed messages. But now the message is loud and clear. There are no mixed messages. Everybody should wear a mask when you leave the house. Keep one in your car. If you know how to make a mask, on the website, we have a video of how to make a mask. It should be tightly fitting. You should wear it over your nose. Every time you touch your mask, you should wash your hands. You can reuse your mask. If you get those cloth masks, you just have to wash them. So, there's lots of information about it, but please, please, please wear a mask, stay 6 feet apart, and wash your hands, with soap and water for 20 seconds or sanitize. So the other thing I just want to tell you about, just in general, the numbers. So Kentucky cases, there's now 19,653 people in Kentucky. Deaths in Kentucky is 629. And so yesterday, on the 13th, there were 4 new deaths: a 79-year-old man, a 90-year-old woman, a 60-year-old man, and a 77-year-old man. And of Kentucky, those cases, the new cases, there are 11 children under the age of 5 with COVID. One was a 4-month-old baby. A lot of these were in Fayette County. So, the positivity rate, meaning the number of cases versus the number of tests done versus new cases, is 4.3%. It used to be 2%. So, we've gone from 2 to 4, where people are becoming more positive. So it is an issue. We are, every state, a lot of states are spiking. We are increasing in Kentucky, and that's why the governor did put the universal masking guidelines into place. So there's a lot of new cases. The deaths, though, are still mostly in older adults. So, we definitely represent older adults. So our job is to keep these older adults safe. And so I think some young people think, oh, they can't get it. Well, definitely young people can get it, but people that die are mostly older adults. And what happens is younger people then transfer it to the older adult. So there are a lot of cases in the Kentucky State Reformatory. On Sunday, there were 3 cases, and on Monday, there were 52 cases, and 47 were inmates and 5 were staff. So that's having a big spike at the Kentucky State Reformatory. So definitely wear your mask. The other big news is that tomorrow, July 15th, the nursing homes, the skilled nursing side of it, are starting to accept visitors. About a week or 2 ago, the personal care assisted living side started accepting visitors. And so each nursing home is kind of having its own rules and regulations. Most of them are having people sign a waiver saying there's never, 0% risk, but they do say you have to wear your mask, you have to wash your hands. So it's a lot of stress on the nursing homes because they're already like minimally staffed, like barely staffed. And now the staff are being required to do more, like they're having to make sure the patients wash their hands all the time. They're having to make sure they do temperature checks all the time. So it's a lot on these nursing homes. So please, if there's any way that you can help the nursing homes, please do so. And just follow the regulations for each facility. Most of them are having the visitation like they have to be in a common area. So it's usually like just right when you walk in, there's a lobby, and that's where the visitation is going to take place. The state and the long-term task force issue a lot of guidance, and we don't want people walking throughout the whole building and just lollygagging around. And so we want them to be in a controlled setting, 6 feet apart, and they have to follow all the guidelines and wear the mask. So, so it's exciting that families are now going to be able to see their loved ones face to face, not through a glass window. But we just want to do it right. We want to do it safely, so there's not a big spike in the long-term care side of things. So, just double check with each facility before you go to find out the rules. And most of them are making appointments, so they're only going to do like 4 visits a day, or 4 visits in a half day, or something like that. So, and I'll be available for questions. I know Dr. McKinney has a lot of good things to say, so I'll stop there. Thank you all.
Thank you, Dr. Furman. We are very excited to welcome Dr. McKinney back for a second time to speak with us. Previously, he talked to us about the lessons learned from the 1918 Spanish flu. And today he's going to talk to us a little bit about pharmaceutical interventions for COVID-19. Just a quick recap. He is the Professor and Associate Dean for Research at the School of Public Health and Information Sciences at the University of Louisville, where he also serves as the Director of the UofL Center for Health Hazards Preparedness and the Commonwealth of Kentucky Local Performance Site for the Health Resources and Services Administration Region 4 Public Health Training Center. And he is board certified in internal medicine and a fellow of the American College of Physicians. Dr. McKinney, thank you so much for being with us again today. Last time we were so excited to listen to what you had to share, and so we're really happy that you can explore with us what we know to date on pharmaceutical interventions for COVID-19, including the drugs that have proven to work and the ones that look promising. And then you're also going to share a little bit with us about the development of a vaccine. So I'm handing it over to you now, and thank you for being with us.
Thank you so much, Dr. Fall and Dr. Furman, for inviting me back. It's always a pleasure to join with the group here and to share some insights about what's going on with regard to the COVID pandemic. I think that everyone's heard a great deal from the very beginning, obviously, about numbers. We know that the case count in every state, in every locality, nationwide. We know that the problem really is largely focused on the U.S. and in the world situation right now. Cases expanding, especially in the southeast and southwest, along the Gulf Coast and so forth. So, and we've done relatively better than other states so far, but the numbers are beginning to increase, and we're always on the cusp of something major erupting. So, rather than focus solely on the numbers, though, I thought it would be useful to talk about where the bright spots are on the horizon. We don't have the magic bullet yet, the silver bullet that will be the perfect solution for the COVID pandemic, but there are some hints that one might be coming, and I'll share those details with you as we discuss today. The other facet of, along with the numbers in cases of COVID, we hear a lot about the availability of diagnostic tests. So, are there enough test kits and swabs and things like that to make the diagnosis? But we don't hear nearly as much about the treatment agents, the therapeutic agents. And so what I did, myself and a colleague in the Infectious Diseases Division did a formal review looking at the national website called clinicaltrials.gov. This is a publicly available site where all clinical trials in the US are required to register. We looked at all the trials that involved COVID-19. There are a lot of international registrants on that site too. We decided to focus on the US trials because the trials that people here in this country can get their patients enrolled in are the ones that are ongoing here. So we wanted to focus on the US trials, and did so just about 5 weeks ago. We did a formal review and looked at all the numbers. At that time, there were 151 clinical trials in the US ongoing. And I think that number probably is startling to most individuals because we don't really hear about all those trials, but indeed there are quite a number. And we looked at the categories that those trials included in terms of the types of pharmaceutical agents. So this was focused on primarily medications that are available and considered as possible treatment agents or prophylactic agents for COVID. And the one grouping of medications that was by far and away the leader among all studies by number of trials and a number of patients enrolled in trials were the anti-malarial drugs. I guess that's not too big a surprise. The biggest one of those was hydroxychloroquine. We've heard a ton about that all over the media, a lot of interest from the very beginning. We heard that there was an emergency use authorization granted hydroxychloroquine early on. People began using it kind of left and right, both in and outside of clinical trials. But actually that emergency use authorization has been withdrawn for hydroxychloroquine, and the Food and Drug Administration felt that the evidence was insufficient to have that status afforded to the drug, based on the fact that the early results did not seem nearly as convincing of the beneficial effects, and because there were harmful effects showing up as well, especially with regard to conduction system of the heart being affected, because this drug was given at doses that were higher than were normally seen in malaria prevention. Low doses required there for therapeutic benefit, potentially for COVID. Much higher doses were being employed, and more side effects were being seen. So that number reflects sort of the early excitement about the antimalarials, but I think that those numbers are going to dwindle over time as the trials complete, and they're not likely to be nearly as many involving those agents. The next grouping of importance based on number of trials, number of subjects enrolled in trials, were the antiviral agents. The antiviral agents are the ones that try to keep the virus from reproducing itself in the human body. And the number one agent being studied there was the agent remdesivir. We've heard about remdesivir. That drug was also granted an emergency use authorization. That's still in effect because a clinical trial has actually shown a benefit from that drug in terms of reduction in length of stay in hospitals for severely affected individuals. So remdesivir was probably the very first agent to really gain attention based on a trial that indicated its benefit. There are other antiviral agents. I won't mention them all because there are a number. Many of the names are unfamiliar, and the data are really not in on those at the present time. There are also a very wide group of drugs called immunomodulators being studied. Now, an immunomodulator is a drug that either ramps up or ramps down the immune response to an infection. So it can augment it, or it can decrease the amount of immune response that's ongoing. So the immunomodulators include a prominent number of drugs whose names end in MAB, so they're monoclonal antibodies that act against various mediators of the inflammatory response, things like interleukins and so forth. And those are being very widely studied. But there are also a few agents you might not expect. There's a drug called Colchicine that's being looked at in several thousand patients. Colchicine is a drug that's been used forever in clinical medicine to treat gout, acute gout, a disease you don't talk about a great deal these days, but it has an effect at a microscopic level biochemically within the cells to modify the immune response. So that's being studied as a potential agent. And also actually it's a vaccine, but it's called the BCG vaccine, which is an anti-tuberculosis vaccine, not used in this country as a TB therapy, but it's used as a cancer therapy to rev up the immune system. So as an immune modulator, it activates the immune system and to help eliminate the threat of the viral invader. So that's being looked at in a small number of trials here. And then beyond the modulators, we get into antibacterial agents, drugs that we consider not effective normally against a virus, but they have an augmentative effect, probably in either getting other drugs into the cell that are effective or having different effects than they would against bacterial cells. So they're being looked at in a small number of studies. And then the vaccines, there were only 3 vaccines listed being studied in the US as of the end of May. 2 of them were RNA vaccines. One was a DNA vaccine. I'm going to talk about those in detail later, but that number has already expanded. And of course, this clinical trial situation is very fluid, very dynamic. It probably changes every day, but we'll be looking at it over time to really see how the numbers vary. But then there are the drugs that work against the renin-angiotensin-aldosterone system. These are drugs that are usually considered antihypertensive agents, and they're in there because the receptor for the virus in human cells is an angiotensin converting enzyme 2 receptor, and the idea is that if you can affect that receptor and keep the virus from invading through that point of entry, you will have an effect on the disease. And then blood products. Convalescent plasma comes next in terms of number of subjects enrolled. There are several thousand people enrolled in those studies. So that looks at individuals who've recovered. You harvest their blood, you take out their blood cells, their red cells, their white cells, and their platelets, and what you have left is the plasma. You infuse that plasma. It has a lot of antibodies in it. Presumably that would be effective against the virus. And so that is certainly one strategy being looked at in a major way. It also has, of course, plasma, many other proteins and things beyond the immune globulins, and things like clotting factors, for example, that could be a problem over time because we know that one of the things that the virus does is cause excess clotting, both peripherally and in the legs, for example, in deep venous thrombosis, blood clots in the veins and the legs, and also in the central circulation, including the brain. And then there are a number of drugs that are used primarily in treatment of cancer, anti-neoplastic agents that are repurposed, that are enzyme inhibitors that have an effect on the virus and its ability to multiply in the cell. So those are being brought into the play here. And there's also, interestingly, there are 2 studies of low-dose radiation therapy in treatment of COVID. Now, you wouldn't think radiation would be effective against a virus, and the radiation is not designed to kill the virus directly, but it's to alter the immune response to the virus. So people whose lymphocytes are too revved up and start making excess amount of inflammatory mediators, you can actually control that with apparently quite safe levels and very low levels of radiation to shut that off pretty promptly. And then as we get down the line, there are actually a number of studies of stem cell therapies. So stem cells can get into the system and again alter the immune response, and that's more of a theoretical issue because we've not seen any of those, of course, that have actually worked in practice. But in theory, they should be able to modify the immune system and allow individuals to recover more quickly from the viral insult. And then a few studies in the US of steroids. There's a couple of big studies of methylprednisolone, which is the commonly used steroid in a lot of ICUs in this country. And interestingly enough, there was not a study in the US at that time of dexamethasone. Dexamethasone was the other drug that's been shown in a human clinical trial to actually be effective in reducing mortality from the virus. Dexamethasone was studied, though, in the UK. It was based on an international study done in England of people who were very ill in the ICU who received dexamethasone. Most of them were either requiring oxygen or on the ventilator. And the idea is that these steroids probably, address the overactivity of the immune system that leads to things like leaky capillaries in lungs, pouring out of fluid into the lungs. And when you get fluid into your air spaces in the lungs, you can't exchange oxygen or get rid of your carbon dioxide. So you go into respiratory failure as a result. So the dexamethasone, along with remdesivir, are the only two agents that are currently out there that are proven by clinical trials to actually cause improvement in the disease. But many, 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 as I said, I'm just going to wrap up here on that list, are currently under study. And the last group is a miscellaneous set of agents that includes things as diverse as zinc, as vitamin C, ascorbic acid, things like attempts to use betadine or povidone iodine, which is a topical antiseptic, or chlorhexidine as mouthwashes to try to kill the virus if it attaches to receptors inside the throat or gets attached there. You try to kill it before it can invade the body. So quite an enormous range of different therapeutic agents being looked at. And the one thing that, again, this being a snapshot in time that we took a few weeks ago, that we are expecting to change in a very major way just over the next few weeks, is the first place, which is being held by the antimalarial agents. Then that should be probably dwindling over time. And the vaccines, which were down the list a bit, are going to start expanding in a huge way as the clinical trials in the phase 3 system ramp up, and they will almost certainly swamp every other category as we go into the early fall here. And before I get into a discussion about the vaccines themselves, maybe it'd be a good time to pause and ask if there are any questions at this point about what I said.
Yeah, we have one question from Colby. He's an acupuncturist and a clinical herbalist, and asking, is anyone looking at the phytopharmaceutical therapies being used in hospitals in China and Taiwan? There's some research coming out of China showing that 1 or 2 herbal formulas in particular are reducing both symptoms and length of illness in a statistically significant way. China has a history of success integrating herbal treatments as standard care in dealing with SARS, avian flu, and other respiratory and infectious diseases. The therapies are considered immune modulators and antivirals, and typically they can be modified for specific symptomalities. Who wants to do a pilot study?
Okay, well, so obviously there's this divide that's out there between Eastern medicine and Western medicine in terms of focus and relative emphases. There are no trials ongoing now that I'm aware of that we found in our review of herbal treatments or preventive agents. There are no phytopharmaceutical agents specifically that are being used in China or Taiwan that are actively being studied here, at least as of the date of our review. I don't think there's any large-scale interest in looking at those in the US. Worldwide, of course, there is. Clearly in China and probably in many parts of Asia, those are being studied. But again, just sort of a cultural divide, difference in philosophy and emphases over the centuries in what we use to treat diseases and our approach to them. So the short answer is no. If you want to do a pilot study, certainly talk to somebody in the nearest medical center about your ideas, and takes a while to get one rolling. But I think the stage is wide open for people who have creative ideas that make sense and that are safe to try to look at those in a controlled fashion.
Mm-hmm. Andrea is asking, so currently only remdesivir and steroid are approved for use. Are those the only 2 drugs that's currently approved?
Those are the only ones that have demonstrated efficacy, okay? The other agents that I mentioned, the whole variety of agents, are being looked at in experimental studies. So controlled clinical trials, they have approval as experimental agents to be studied. The emergency use authorization was made available, as I said, for hydroxychloroquine because it looked promising. Then it was withdrawn because it looked like it was too damaging. But remdesivir was given the EUA, so that means that can be used outside of a clinical trial in treatment of of COVID patients. So if you've got somebody who looks like they would benefit, and most of the people who are likely to benefit from remdesivir are those who are at least sick enough to require some oxygen therapy, so they can't get enough oxygen into their systems from their lungs, or they're on a ventilator. Those people certainly would qualify for remdesivir, whether or not they're in a clinical study. So you can just go to your local hospital pharmacist and make that request. If they meet those criteria and their liver is healthy and functioning well, normally they can get remdesivir. The steroid dexamethasone is already approved. It's widely available. And so there's no problem in access to dexamethasone. It's also extremely cheap. It's a very, very inexpensive agent. The doses that it's given in are 6 milligrams once a day. So it's a once a day dose, either intravenously or orally, and usually given for 5 days. So it's a minimal cost, highly effective, and doesn't require any kind of special authorization for its use.
Thank you. Next question. Any such thing as a donor directed as at this time for convalescent plasma? Is that an issue yet?
So I don't know the specifics of how the plasma donations are being handled. I don't know that you can direct that to a specific individual. That might be possible, but I've not heard about any of the arrangements that are being made. That if you wanted to donate for a specific person, if you could do so, it might be. It certainly might be feasible. It may depend on the number of people who had
Alexander, what are you doing?
Go ahead. Sorry.
No, just keep going. Someone was
Okay.
not muted. Yeah.
Yeah. I would say just check with your local Red Cross or hospital blood bank and see if that can be done. There might be special arrangements that can be set up for you.
And Dr. McKinney, this is Kristen Furman. Is this plasma that they're giving plasma for people that have recovered? Is that working or not? Or have you heard, is that a really good treatment for COVID?
So, the results of the actual clinical trials are not in yet on that. So all we have is anecdotal information. And clearly there are some people who say, I was going down the tubes, I was on a ventilator and nothing else was working. I got the plasma and all of a sudden within 24 hours, I was better. Well, that might be from the plasma. It might not be. And who knows? The trials will tell us. I suspect that if that's going to be effective, probably a more refined version of it will be identified first. Like you can, don't have to give so much extra material, all the other fluid and all the other proteins in the plasma. If you can separate out just the immunoglobulins that are in there and give it as a smaller volume, that might be just as effective with fewer side effects. And as we talk about antibodies, there's actually a new pharmaceutical company that's manufacturing monoclonal antibodies, or kind of synthetic antibodies that can be used, much like was actually done early on with Ebola. Use a laboratory generated group of antibodies that you can give as a pharmaceutical agent. So that will be another alternative. They'll be coming out pretty soon, and then we'll see probably used in a significant way over the coming months.
Andrea is asking, she says, my uncle is the director of respiratory medicine at University of British Columbia. He's part of a massive study currently just in Canada looking at nitric oxide as a nasal spray for use in prophylactic early intervention for COVID. I'm curious if you've seen anything like that in the USA.
Interesting that you should ask that question, because yes, that actually is being studied. I didn't get down to that level, but there are 2 studies in the US of nitric oxide. Let me see if I can find my listing here. Yeah, 4 studies. There are 4 studies in the US. And the idea there is that nitric oxide appears to be important as a pulmonary capillary vasodilator, artery and capillary vasodilator. So you can get more flow to the lungs and get better oxygenation by doing so. And also, interestingly, at least in vitro, that is in the laboratory, test tube type setting, petri dish setting, nitric oxide has a direct inhibitory effect on the virus. So that is actually being studied. There are studies both of prevention and of treatment. So they're giving some patients who are on ventilators extra, inhalation of nitric oxide. It's all inhaled, not a pill form, not an injection, but inhaled nitric oxide. And there's also a study of healthcare workers that was ongoing in Boston, where they would put a mask on and inhale nitric oxide for 15 minutes before going into the COVID unit to see if that had a protective effect on their getting the infection. So those results are not out yet, but that's a very interesting concept. That would be nice if that worked, because it's so easy to deliver, so simple and appealing. But we'll see. We don't really know. A lot of things that work in vitro in the laboratory don't work for a whole variety of reasons in the intact human being.
And just then giving a link there to a specific study on this. And then Barbara's asking, just trying to understand the vaccine world and how it works. There are studies that indicate the virus is changing and mutating. I just read a report that people who have been affected by the virus, whether symptomatic or asymptomatic, may only have a 3-month immunity. How likely is it that the vaccine will work the way vaccines are intended to work, creating herd immunity?
Wow, that's like the $64 billion question, I guess. Huge issue. We don't know the answer to those questions, unfortunately. We do know that the virus, in fact, is mutating, and that there's one certain form of the virus that seems to be predominant now in the U.S. as a slightly modified version of the one that appeared in Wuhan, but apparently it's similar enough in terms of its structure that the vaccine trials are not going to be affected by that slight mutation. Now, further mutations could occur. That could be an issue. That's always one of the things you worry about in a vaccine trial. So this is actually a good lead in to that whole concept of the vaccines. But we don't know, of course, how long people with native infection have antibodies. Some people seem to lose them quickly. We don't know how long the majority will maintain them. And we don't know if other forms of immunity are even more important than antibodies, because there's, antibody-based immunity and there's cellular-mediated immunity. And that can be maintained whether or not the antibodies are present. So it's possible, even if your antibodies are gone, that you have immunologic memory in your T cells, and that will be sufficient to protect you. So a bunch of unknowns here, and we're only going to know the answers as the vaccine trials emerge. But let me just say, most people are aware that the influenza vaccine, which is the one that probably is given in the largest number of doses of any vaccine in the U.S., because the target population is the entire U.S., right, every year. So you want to immunize as many people as we can in the whole country annually. And to do that, we make close to 200 million doses annually of influenza vaccine. Now, traditionally, most of that is made by inoculating eggs. About 80% of the vaccine against flu, it comes from eggs. And so that means you've got to have a lot of eggs to inoculate, to grow that virus. And in fact, supposedly there's, in excess of 10 million eggs, fertilized eggs that are used every year in production of vaccine. And the egg producers are a guarded list of individuals. The farmers whose hens are producing those eggs, they are basically top secret. Nobody knows who they are, because it's it's strategically important for the country to have that group protected. We don't want anyone interfering with that supply, because it could damage our ability to respond with vaccine production. But So there are two other ways in which flu vaccine now is made beyond the use of eggs. There is a cell line that involves canine or dog kidney cells, in which the virus is introduced and grown in those cells, and then it's harvested. And the main reason when you grow it both in the eggs or in other cell lines is you want to harvest the main receptor protein, which is called the H or hemagglutinin protein from the virus. So you've heard of H1N1 virus and H3N2 virus. Well, the H is the protein on the virus that allows it to attach. It's the same as the S protein or spike protein for coronavirus. So that attachment point is the key, the key issue that all of the vaccines are trying to address, both with flu and with COVID. So if you grow the virus up for flu, whether it's in eggs or it's in dog kidney cells, you harvest the virus and you separate out the H protein, purify it, and then inject the H protein, which is the main part actually of the vaccine that we get every year. So the main difference in strategy with COVID is that, number one, it doesn't seem to grow very well, if at all, in eggs. So the egg strategy is not going to work. And we don't have, a huge number of other cell lines that we can grow the vaccine in, the virus in, currently in the US. So the strategies now for coronavirus basically are to give humans not the antigen or the attachment protein to make antibodies to, but to give us the genetic material that instructs our cells to produce that internally. So these are RNA vaccines or DNA vaccines predominantly that will tell our cells, make this spike protein, and then our immune system reacts to that spike protein. So we're going to a different level and a very different strategy in our vaccine studies and plans for production. And I think you've probably all heard of Operation Warp Speed. This is the plan to get close to 300 million doses of vaccine out there by January of 2021. So within 6 months. And to do that, there's six vaccines primarily under study in the US. Two of them are RNA vaccines, where you inject that protein, inject the nucleic acid, and instruct our own cells to make the spike protein, and then our immune system reacts to that with antibodies. And so if we're exposed to the virus, then our antibodies will attach to the spike protein and prevent infection of our cells. So the use of the RNA is the one approach. The other, directly to give RNA in a lipid envelope and get that directly into cells. The other strategy is to give people a virus, a relatively harmless or virus incapable of replicating and reproducing itself, that has a bit of RNA in it, that will introduce the RNA into our cells, that will instruct us to make that spike protein to which we respond. And then lastly, the very newest competitor now that's made it onto the list, apparently, of the warp speed candidates is one that actually produces the spike protein synthetically in the lab, and just introduces the spike protein by itself into the body and allows our immune system to react directly to the spike protein. So these different strategies, most of them are unproven in terms of actually having a vaccine that's been developed along that line of thought, and one that has been shown to be effective. We don't have prior data on any other RNA vaccine that's ever been used in a human. So no one's tried that route of inquiry and treatment or prevention before. So the idea is that by trying so many different strategies at one time, surely one of them, or more than one, maybe two or three, if we're lucky, will all work, and that we can get to that magic number of 200 to 300 million doses within a short period of time. And that once that, any one of these shows relatively solid promise, then the pharmaceutical company will actually start to make it in large amounts, even before it's actually finally proven. So it's going to be manufactured in the labs in large quantities based on the best available information and promise rather than proof. And then if the final studies prove it out to be safe and effective, then it'll be there and ready to be employed. So questions about that in terms of strategy? Clearly, we're in a much different place with this vaccine than we've ever been before with any other vaccine. I'm told that the most rapidly developed vaccine prior to this was a 4-year production of I believe it was a mumps vaccine, got out in about 4 years. But doing it within 1 year turnaround is unprecedented. So we've got to do this very carefully, and it's going to require a lot of field trials. So they're going to be looking for a lot of volunteers. Each of these studies, each vaccine candidate will probably try to enroll 30,000 volunteers, and the companies are already looking for people to volunteer at every level. So people in every age group, from every risk profile, from every racial background and so forth, to make sure it will work in every group as we need it to, and that those who are most vulnerable can be protected.
Thank you, Dr. McKinney. Can you maybe just let your camera show a little bit better to your face, because people are saying they can't see you well, if you don't mind.
Okay.
I'll
move closer. I'll move closer.
Thank you so much. Jennifer is asking, how accurate are the coronavirus and antibody tests? Are the tests able to detect mutated forms of the virus?
So the tests that have been used so far for antibodies are really all over the board in terms of accuracy. And that is one of the problems. The early tests lacked very good sensitivity, that is, ability to detect people who've actually been infected. And specificity was not terribly good. I mean, it was okay, but sensitivity was especially bad. So we are moving in the right direction, and we are trying to get more focused on not just whether there's an antibody, but whether the antibody is a neutralizing antibody, that is one that can truly prevent infection. So there are other antibodies that don't confer that degree of protection. The antibody tests, in terms of detecting mutated forms, I'm not aware that the antibodies themselves can actually, that they are distinct, and that you can tell from the antibody which version of the virus you've been exposed to. You certainly can. The tests on the nasal swabs for the RNA of the virus, you can tell directly from that, of course. The antibodies, I've never heard that there's a specificity of the antibodies that can detect the slight mutation that has been observed already.
Andrea is asking, if COVID shows to be something we do not have lasting immunity for, is it reasonable to wonder if we'll eventually utilize a combined COVID-influenza vaccine as part of our annual preventative care?
Yeah, I think it's very reasonable to look at that as a possibility. We thought, for one thing, that the COVID was going to behave a lot like flu and go away largely in the summer, as influenza does. Influenza continues to circulate actually in the US even in the summer, but it's such a low level it's hard to detect. But COVID has not done that. It is at record numbers, as you've all seen and know. And we don't know if that's entirely because people are just crowding together, or because the sunlight and heat have less an effect than we had thought in the past. But if in fact the antibody response to the virus and to the vaccine is less robust than we had hoped, it's very possible that there'll be a need for an ongoing repeated vaccine on some regular basis. against COVID. Again, this is just an entirely an unknown thing. Hard to predict, but certainly one possibility that's been discussed at the highest levels that in fact may be a need.
This is Christian, Dr. McKinney. So do you think, you see these pictures of polio when people are lined up to get their polio shots and get vaccinated. I mean, do they have, I would hope that the public health department's working on a plan to immunize people in all areas evenly and not have the health disparities that we're seeing so far.
Yep. As you know, Christian, we had a major strategy in 2009 with the H1N1 swine influenza vaccine. We had to get that vaccine out very quickly. We used a drive-through immunization approach. So we had Papa John's Stadium there, Cardinal Stadium, outfitted with a number of drive-through tents. People could get in and get out quickly. We immunized around 20,000 people in 2 days. So that kind of approach probably would be the sort that we would need to immunize large numbers of folks again, if the vaccine becomes available in large chunks, large amounts. The other thing that's being looked at, I'm telling you, because I have been fortunate to sit on some of the discussion groups that CDC has had about the vaccine, is the key issue that's out there right now is who is the first priority group to receive the vaccine. And that's highly controversial. But I mean, the simple answer, who should get the vaccine first? The persons who need it the most, who would benefit the most from it. So, healthcare workers are being looked at as being priority because they're exposed every day on a regular basis. And we have to keep the healthcare workers out there or the whole system of healthcare would collapse in the US. But then beyond that, people who are at high risk based on age, based on underlying disease conditions, socioeconomic status, and so forth, probably will get prioritized next. And then the other issue is if you've got somebody who's highly vulnerable, but who may not be able to respond directly to the vaccine, should you immunize that person, or do you immunize the people who work around that person? Right. So if the elderly in a nursing home may not be able to mount a good response to the vaccine, the strategy would be to immunize everybody, all the workers in the nursing home, so they can't bring the virus in, and their families as well, sort of cocoon them in by immunizing their contacts. So there's different ways this protection of the vulnerable could go. We hope that everybody will be able to mount a good response, but if they can't, we have to immunize those vulnerable are in contact with.
We have a question here. Early in the meeting, you referenced the silver bullet. Are you encouraged about any of these trials at this point?
Well, I think that there's hope in a lot of them. I don't see, except for the hydroxychloroquine, which started out with a bang and then ended with a bust. I don't see a great deal of hope there. But I see that almost every other avenue that I mentioned at least has some potential role to play. I think that clearly, getting a drug that keeps the virus from reproducing itself, if we had that, we would be, in fantastic shape. Remdesivir helps to do that. It's not perfect. There may be a better agent that will emerge that will be even more effective in reducing replication. So I think there's a lot of hope in the antiviral group. And I also think that the synthetic antibodies, if those actually do, can get online quickly and can be introduced into the population, without too much delay, I think those will likely have a major impact as well. And then there are always surprises. You do the trials because something looks promising, but you're not sure how good it's going to be. I think that something may well emerge in one of these, lesser known agent categories that may be a huge surprise because we're addressing therapeutic trials all over the board in so many different categories all at one time. There's bound to be something that will emerge that will probably give us a surprise in terms of its benefit. Maybe it will be, the nitric oxide. maybe it will be one of these various immunomodulator agents that can keep people from entering cytokine storm, which is, immune system out of control and leaky capillaries, and you're going into shock and so forth. So I'm very hopeful, and I think that with the diversity of approaches, something is going to emerge here within the next few months that will be another breakthrough for us.
And this is Christian again. I had a question. If you knew, there's been controversy about when to intubate people. They used to, I think at the beginning of this whole pandemic, they were intubating people right away, and now they're not intubating people so quickly. I'm not kept up with it exactly. That's one thing. And the other thing is about blood clots. A lot of people, when the cytokine storm hits, then people are getting all this blood clots and losing limbs, and kids and everybody. So what have you heard about that, when to anticoagulate or not?
Yeah, so there was a move early on to consider just therapeutically anticoagulating everybody who gets into the hospital. NIH and all the expert committees now say don't do that. There's not enough evidence that that's both safe and effective to do. But I think everybody who's in the hospital now gets prophylactic. As many hospital patients would anyway, but would get at least prophylactic level anticoagulation, because the risks are so high. I think people are, if it's possible to mobilize them, if they're able to move, keep them from being at total bed rest at all times. In terms of intubation, I think you're right. I think I'm not a critical care person, but from what I've heard at every level on critical care is that the interest in intubating rapidly is not there. They try to postpone that. And if you see somebody whose oxygen levels are declining, I think the interest in getting remdesivir out there quickly and getting dexamethasone to try to forestall intubation is probably the preferred approach right now, and to use intubation only when necessary, not try to do it as early as it was being done.
Right, because some people, their oxygen levels are lower. I had a patient in the office, but they really were asymptomatic. They didn't feel short of breath, and they were doing okay. I mean, so yeah, it's like this balance, because intubation itself has side effects, so.
Oh yeah, very, very clearly, and has risks of, secondary infections that can be introduced, bacterial infections largely. So those can be dangerous too. And so intubation is, carries its own set of potential hazards. You want to try to avoid those if you can, by treatment with other drugs to improve the oxygen in the bloodstream.
Luann is asking, is there still only a 20% chance of survival with intubation?
Well, that number keeps changing all the time. I don't know our numbers locally, but I see that number actually likely improving. I don't think that number is going to be static. But clearly, once you get to the level of intubation, you have much more severe disease, and your likelihood of survival diminishes if you're that sick. But as we utilize the interventions earlier to keep people off the ventilator, I think that the mortality rate will continue to decline, as we've already seen some evidence of. And also, if we have more younger people who are infected, their outcome we know is better than folks who are a very advanced age, although they're still impacted, no question about it. We're not trying to minimize the disease as being nothing. It is something. It's a very significant importance. But in terms of mortality, there's a benefit on the side of younger age. And so hopefully if the downside of the pandemic is more younger people are getting it, maybe the upside is at least their mortality outcome is likely to be much improved. And so you've got all those different issues to deal with at one time, but major strategy obviously is to interrupt transmission as much as possible. And the only way we have to do that right now is through the ways that have been discussed, from the very beginning: good hygiene, hand washing, masks, and distancing. Yeah.
And I don't think we know the long-term consequences of COVID. Like, I think it's probably going to have long-lasting people that were intubated and had lung disease with it are going to have probably lung disease their whole life, COVID lungs or something. I don't know, but we'll see. We just don't have that data until years down the line here. But
yeah, there's actually a move, interesting that you mentioned that, Christian, a move underway to establish a post-COVID clinic at the UofL to study people who've had the disease and to see what's going on with them at many different levels, look at their heart function, look at their oxygen levels, look at their exercise tolerance, look at their mental health. There's a lot of psychological and neurological effects that the virus has. This is a disease that doesn't just affect the lungs. It affects most every system in the body. It's just incredible. And it can be very devastating in the near term, and it can have long-term consequences. We don't know what the long-term consequences are yet because it hasn't been around long enough to study, but we're interested in getting that data.
Mm-hmm. Andrea's asking, probably the last question, is saying, because COVID is not a well-behaved virus, it affects people so differently, is it appropriate to assume that we will have multiple gold standard RX depending on the patient's symptomatology?
Yeah, I suspect so. I suspect that there'll be, as more data emerges, people with certain types of complications will get directed into certain avenues of treatment, and those with others will go down into different therapeutic agents. That's almost certain to happen. Hasn't happened yet, really, but that's because these hundreds of trials that are out there are still ongoing. Once they're concluded, hopefully the information will be positive on at least a handful or more of them. Then we can really see what works best for certain individuals and kind of tailor that therapy according to their needs.
I have one last question, Dr. McKinney, that I was hopeful you can give us a final statement on. And that is, when we closed down in March, it didn't look as bad as it looks now. And now everyone is starting to open up. And to me, it's like a conflict in my brain. We're going back to normal with the cases just escalating. What advice do you have for us as a public health expert?
Well, I think that the prudent thing to do at the present time is for those people who don't have to be out and about, not to be, those people have essential roles to play, and you need to be out there, be extra strict in everything that you do. Obviously carry sanitizer with you, wash your hands whenever possible. If you're touching any kind of a surface that's in contact with the public, doorknobs and things like that, bathrooms and so forth. And certainly to wear your mask. Don't fail to wear the mask at all times when other people are around. The other thing is that the importance of ventilation systems may have been, underrated or understated early on. We know now that, in some cases there are people who perhaps can produce not just droplets of, but aerosols of virus, so very fine particulate matter that may stay suspended in the air for long periods of time. So if you're in a room that doesn't have any airflow, you're at higher risk for, if there's somebody else sharing the airspace, of inhaling virus. So we're looking in a big way at ventilation in all of the buildings at the University of Louisville and trying to augment fresh air exchange to get more airflow in and get the bad air out and outside air in. Most of the newer buildings have excellent air exchange. Some of the older buildings don't, but we're going to try to do the best we can to push up the airflow whenever possible to reduce that likelihood of transmission. Okay.
Well, thank you. We just want to make one statement. You talked about the UofL COVID clinic to look at the people who had the virus. And we are actually part of that discussion at the Traeger Institute and the Optimal Aging Clinic, hoping we can get funding to be supportive of that clinic in our own clinic. So we will let you all know once we have more information. So with that, we are 2 minutes out before the end of this session. I want to ask Justin to do a quick poll about trying to determine our way forward with these discussions. If you all can just answer that very quick question. Starting in August 2020, which of the following schedules would you like best for these COVID-19 information sessions? That is just a quick survey. And while that's going on, maybe Barbara, there's one more question from Barbara, Dr. McKinney, you're not off the hook yet. If that is the case, what do you think about schools opening, allowing students and teachers to take masks off while in class?
schools opening, allowing students to take masks off while in class. I think that schools opening will depend on the situation just before schools are due to open. If the number of cases ramps up very dramatically, it may be unwise to open schools. If the numbers stay where they are or decline, it may be possible with very prudent approaches here to do it. And one of those approaches is, distancing within the classroom and wearing masks. I can't see any way in which we can get beyond wearing masks in the classroom unless the teacher is up, on a stage like elevation, well away from the class and speaking, like that. The students themselves, if desks are closely crowded, very bad thing. You've got to sort of de-densify the classroom, separating the desks when possible, and getting people used to wearing masks throughout the day. I don't see that there's really any way to allow people to take those masks off unless they're in a huge auditorium where everyone is very widely spaced. That's a different thing. But a classroom, masks are, I think, part of the near term for everybody.
Yeah. Well, Dr. McKinney, what a wonderful session. There's such good comments in the text, in the chat room saying thank you. Thank you for a wonderful, informative session. And we will hope to keep everyone up to date. It seems like the poll is saying we should keep the weekly sessions going. So we will listen to you all and send you the new theme for next week. Thanks, everyone. What a wonderful session. Thank you.
Really good. It was really good, Paul. Bye.
Thank you. Bye-bye.